like enough handouts. Okay. Since 1999 or so, and worked in various fields in family medicine, internal medicine. Where else have I worked? Allergy, immunology, gerontology. Anyway, I've been around for a while, but now my home is in ENT, and I absolutely love it. And this is a huge part of my day. This is a huge part of a lot of people's days, and it's usually a large source of anxiety and annoyance when somebody comes in and says, I'm dizzy. So we're going to work through some of that today. We have some learning objectives. I'm going to go through a bunch of this stuff, but really the lion's share of things here are that you're going to be doing Dix-Hall pikes and Epley maneuvers on each other and figuring it out and coming up with a real spiel, what you're going to tell the patient. I'm going to practice those sorts of things too. And so I'm hoping, my goal is that you all walk out of here feeling confident as to identify what is positional vertigo, what isn't positional vertigo, and what you need to do about each of those things. All right, so just some balanced physiology. The middle ear, the semicircular canals, and the utricle and the saccule are responsible for picking up acceleration, okay? So you've got in this movement, in this direction, and then horizontal and vertical acceleration. It's the VOR, the vestibular ocular reflex. It tells your eyes where to look. You ever look at somebody when they're looking at the classic thing is you say when you're on a train, I don't know how many people are on a train anymore, but you're seeing stuff go by and your eyes are trying to lock on it. And so you're going to see all this kind of horizontal nystagmus as they're moving back and forth and back and forth. What you see primarily with posterior canal BPPV is rotary nystagmus. And so we have some videos of these things as well. It can be quite alarming to see when you see it for the first time. The patient's freaking out, their eyes are doing crazy things, and everybody needs to stay calm, so because you're going to fix it. So what's actually happening? Everyone's talked about the rocks in your ears, the crystals. Well, what that really is in the semicircular canals. Yes, my ears, my semicircular canals, okay? We've got them. They're not this big. They're really quite small. Both systems, both your cochlea and your vestibular system of each ear will fit on a dime, and they work in concert with one another. So this laser pointer isn't. Well, it's lighting up like it's working, but it's not really working. Oh no. Here we go. Do I have this? Okay. So what's happening here is that this fluid is going through the canal, okay? And in the ampulla of the canal, which are these pieces right here, you have these vestibular fibers. And on top of that is this kind of gel matrix and otoliths. And the otoliths give that gel matrix and those hairs some mass so that when you turn, the switch is going to open or close, sending signals that says, okay, you're moving this way or you're moving this way, whatever it is, okay? When those crystals become dislodged, they just float freely in usually the posterior canal, in the canal, and they change the inertia so that when you move your head, there's going to be this lag and your eyes are going to be searching for what you're looking at, but they're not going to really be looking at anything. They're going to be just kind of fluttering there until you fixate. Or if you move and you find something to fixate on right away, you may not see so much of this nystagmus, but the patient may not, you may not see it as a practitioner, but the patient will be feeling it. So when they say you got rocks in your head, or the crystals are loose, It's not in here. It's in one, usually, of these canals. And this is what I meant by they kind of work in concert with one another. So the right posterior canal, or the right lateral, and all right, so the right lateral and the left posterior canal are in the same plane, and vice versa. So this is why you usually only have one side that's affected and why you can compensate. And even when you have vestibular neuritis, and the whole system is inflamed and you've got protracted long periods of vertigo, it's usually in one ear, and why you can calm it down, usually in 3 days, let your other side compensate. And then you work on strengthening the good side, the bad side again. This is a little dated. Still, a lot of textbooks will talk about central and peripheral vertigo and sort of the importance of distinguishing which is which. And that's not really as important anymore. What's really important is just to figure it out. Because if you have central issues, this is more of a neurology, cardiology issue. And if you have peripheral, it's more of a otolaryngology issue, right? Or probably a physical therapist issue, okay? All right. Looks like a lot of stuff just to deal with vertigo, but it goes by quickly, I promise you. You can do a neurologic exam in 2 minutes for what you need to do for this. You need to just to identify if there's a big neurologic deficit or not. And the rest of your physical exam is normal, your regular normal stuff. Specific things like pneumatic otoscopy, you're looking for, does the eardrum move? Do they start having vertigo and nystagmus when you are puffing air in the ear? Now, that can mean, that's a Henenbert's sign. Do they have any obvious middle ear issues? And then your vestibular workup, which we're going to go through. Okay. It's pretty easy when it looks like this. Oh, I don't remember which one. Or this. Or that. These are obvious things. That's called, I use a Q-tip too often. This throws people off all the time. This is tympanosclerosis. This isn't anything crazy, really nothing really to worry about here. This is just someone who's had a bunch of ear infections. That's bad. A little bad. I mean, you got to take this a little serious. This is a cholesteatoma. These are just keratinized debris and squamous skin cells in the attic of the ear. And as that moves, that can grow into the middle ear system and wrap around the ossicles and cause conductive hearing loss. That needs surgical intervention. All right. Here we go. Not a neurologist. Anybody watch YouTube, Dr. Glockenfecken, the guy, right? I had it. It was going to pop up here where he was just going to rise up in the morning, right? Drinking the tears of med students, You're not that guy, right? You don't have to be that guy. You're looking for gross abnormalities, and you can do a really quick neurologic exam. Is everybody comfortable doing a quick basic neurologic exam? I'm going to put you on the spot. Raise hands if you aren't, because if it's not your field or you need something, I want you to say so that we can get you out of here knowing what you're doing. All right, everybody's expert. Great. All right. I'm not doing corneal reflexes. Let's just get that off the table. Equal face symmetry, that's easy. Close your eyes, open them up, smile. Does that work? Does your tongue go out? Does it move from side to side? Fine. Can you get your shoulders up? Do you hold them up? That's fine. As far as an audiogram, the Weber and Renee test, just distinguishing whether there seems to be an obvious conductive or sensorineural loss. It's only at one frequency, 512. but that can be very helpful. And then proprioception, looking for cerebellar issues, very, very helpful. But again, you're not Dr. Glaucoma, you're not the neurologist guy, you're just looking for gross abnormalities. Okay, Hennebert's sign is normal if there's not any nystagmus. That's when you're doing pneumatic otoscopy. If there's no nystagmus, it's fine. Hennebert's sign can be positive in a semicircular canal dehiscence, Meniere's disease. It's not always. It doesn't mean that if you don't have this sign, the patient, or if you don't have this sign, the patient doesn't have Meniere's. It's just, it could show up with that. All right, here's some videos. This doc, by the way, is Dr. Peter Johns. He is he's retired now, but he is an emergency medicine physician at University of Ottawa Hospital System. And he is a vertigo enthusiast, as he would label himself. But he has put together 100 really very, very high quality videos and instruction. They're all available on YouTube. They're all free. And he's very, very good. I use his videos all the time in instruction. Peter Johns, Johns. That should be on your handouts. I think I gave like a bit.ly kind of thing with some resources.
This woman has no vertical or diagonal skew of her eyes when tested, and this is a Hintz plus peripheral result. This man has diagonal movement of his eyes, and this is an abnormal skew deviation and has a Hintz plus central result.
Yeah. So this is test of skew. All right. So test of skew is if you're covering this one, you need to cover it completely. Don't cover it like this. You don't have to have your hand completely over their eye, but you want to block midline so that they can't see out there. They don't have any fixation, okay, with the other eye. And you're looking at this eye. The tendency is to look at this eye because that's the one that's working, but you're looking at your hand here, and then you take it away and nothing should happen. If you take it away and everything kind of goes, that usually points to a brain lesion. Like you may be looking at your suspicion for stroke, for those of you working in emergency medicine, should be much higher. You should start getting a little suspicious about that. So that's what this is. I'll play it again.
This woman has no vertical or diagonal skew of her eyes when tested, and this is a Hintz plus peripheral result. This man has diagonal movement of his eyes, and this is an abnormal skew deviation and has a Hintz plus central result. Here is an example of unidirectional nystagmus, where the fast component of the nystagmus is to the patient's left and then increases when he looks left and decreases when he looks to the right. But importantly, the nystagmus is still in the left direction. This is a Hintz plus peripheral result.
Catch that? What he was talking about. So when the guy was looking left, he has leftward nystagmus the entire time. So that's the fast beat component of the nystagmus, right? Because it's going to rock back and forth, but there's always a faster beat to it. So the fast beat is this side that it's looking towards. So this it's looking toward the left. It becomes faster when he looks toward his left. And when he looks to the right, it slows down, but it's still beating to the left.
In bidirectional nystagmus, such as in this woman, the fast component is to the right when she looks to the right, and then changes to the left when she gazes to the left. Although not often seen, if it is observed, it can only be caused by a central condition, and it's a Hintz plus central result.
Yeah, usually you're only going to have nystagmus fast beat to one side, always. It may be active in looking at either side. It should be active, and it should be, more active when you're looking toward the side of lesion, and less vigorous when looking to the contralateral side, but it'll still be present. When it's like this is also another worrisome sign for something central. All right, Romberg test. this is the, you stand up, you close your eyes, you fall down or not. And everyone's going to sway a little bit. Everyone, as we get older, we lose a little bit of speed and compensation there. So, a little kid's going to be able to stand there with his eyes closed all day. I could do it for me, I don't know how long I could do it, but not that long. And this usually tells us that there is a cerebellar issue or not, or suggests. Nothing is pathognomonic, it's just suggesting. Stephan Fukuda is helpful to me when someone has difficulty saying in their history, yeah, it's every time I roll over in bed to my left. They can't localize a side during the history. Stephan Fukuda can sometimes be helpful in shedding some light onto what side is affected. And that's the side that I'll start the Dix-Hallpike on, because if they're positive on that side, we go right into an apnea maneuver and you just avoid nausea, usually some vomiting. Tandem gait, again, is another cerebellar test. I hope no one's had to do that on the side of the road, but it does. It's a heel-toe maneuver, okay? There's also another test called the up and go test. I don't know that I have that in here. No. Up and go test is where you put two chairs about 6 meters apart, and you have them sit in one chair, stand up, walk normally around the other chair, and then come back and sit down. And they should be able to do that in 10 seconds or so, normal adults. And that, again, can be a sign of something central. All right, down to business. Dix-Hallpike test. All right, Zlatan. I am, for those of you on Zoom and for the recording.
No.
We're going to demonstrate the Dix-Hallpike.
Again, no picture. Good. Where do you want my feet? Oh, sit here.
So she, as like most patients come in with their canals all lined up for you. And I'm gonna give one of these, but I'm gonna pass it around to the station. It's really helpful to sort of get a sense of how slowly these crystals move, and what explains why you're doing the maneuver you're doing. Why does the apnea maneuver? Why does canal repositioning work? And it is demonstrated in these lovely ways. Not here, but these. So, big one accomplishment. Just for basic Dix-Hallpike maneuver, say, all right, so you're going to have you sit with your legs, right? And let's do, you have to scoot your butt back up. So the reason is that when you go down, you want that hand to be extended about 25 degrees, but you want to move back. You're trying to get this canal to lie straight down, and you'll see that. You'll see that as it goes down. You will also note in some tests that they say, bring that down rapidly. That's not. It isn't necessary. Most people are complaining, they're actively having a problem, especially where it's you don't need to jostle the volcano. Okay, it's going to go. So you're going to notice two things when people go down. Latency and continuability. Okay, so latency is they go back everything's fine, it's fine. Now, whoa! And it's not, all of a sudden, you're gonna want to jump up, you're gonna want to stop. And you're gonna say, oh, we're gonna fix it. So it's worth a little bit of explaining ahead of time. So, all right, we're gonna do this test. Then you weren't sure which side was affected, so we're gonna drop down on the right side first. And if you get spinny and nauseous, we're gonna fix it. Okay, just technically, we're not gonna let anything bad. Right?
Okay.
All right. Follow my instructions. So, how do you do it from follow? Okay. You can, you'll see in even this, they're showing side this and gaze in their eyes. And once you get somebody back, they're like, oh, I need to go to the, I don't know, we're going to go into the, it's all, or, athlete, I'm going to go this way. So have you put your chin over your right shoulder.
And then
You get on. And what you look up. And we're going to lay back. And we'll lay back swiftly, so you just come down nice. There. That's all you have to do. And if you see, oh, there.
oh yeah, just like that.
No, you can't see. In your head, relax. There we go. See, they all, what you're going to see is this canal.
Use your partner in your.
What's that?
Use your partner in your.
Are you going to do one?
What?
So what you see is this. And you notice maybe that those red little crystals in there have fallen down. Okay. And it corresponds to which canal on the other side, what color on the other side? The red on this side is the same plane as which color on this side? Green, that's right. That's how they work in concert with one another. So I'm going to move on. Right. All right. All right. So, yep. Works that way. So now we're going to just say, we'll just demonstrate just how to do the maneuver in this entire. So, looking this way up, down, and this here. I'm fine, I'm fine. Whoa! And they can look at it, so can't they fix it? You know, you'll see it, and you're going to see dots. And you wait. So the pause where you don't see anything and you don't feel anything is the latency. It's the crystals moving through in the middle of the lymphatic fluid to a point where they finally change over the year. Okay? And everything moves. And then it stops. And you wait. You wait at least 30 seconds before. Maybe on. Because there's a lot of there's multiple crystals that come at the same time. And then there's debate on what to do next as far as the process. I would generally just need people kind of slowly through this because I thought they could just move them directly off to this side, which is good. I just kind of move them slowly through this side. I'm usually down here, so I have to force their flow. They don't really all the way over. And then the last maneuver is probably the most important. And that is we're going to roll on your left shoulder vertically. That's a continual around. I'm not getting it down to it. Right? So everyone say, this is great. This is what all your patients are going to do as well. You're going to mention that and they're going to start moving. All my instructions go. Right? So I want you to put your shoulder in your left hip in the middle of the table. Now you come over the island. Okay.
Okay.
Down. And then usually this has so at least it's down there.
Okay.
And wait for everything to stop spinning. And wait an additional 30 seconds or so. in your shoulder. And then you to the side of the table and you sit up. So generally, I keep my hand like this sometimes too. I have patients say, okay, we're gonna come up, okay, and then I want them to keep their head over here, and then come up. And then you come on, and I stay here because then patients get kind of and they say, oh, it's a miracle. Miracle. It's a good weekend. I'll take this off. And what you'll see the second time, I think what well is the whole suitability part, which is that the whole reaction to the silence and allows bigger than you think about it at all. Sometimes they'll move with no. Sometimes you need to do a couple. Sometimes when you roll over, you'll dislodge something that will go into the horizontal. There's a different kind of misguidance for that. So if things get weird after that, and then misguidance will be like this doll-eye stuff, which will come up. And it really looks like they're looking out of a train window. It's the horizontal canal. Okay, back to another couple of slides. So here, this woman is, they're going to do a Dix-Hallpike on her. She's looking to her left. This is her left posterior canal that's affected. Whoops. That's another guy. Latency starts getting more vigorous. And then it slows down. And then I think he does this in slow-mo again. Yeah, here's the action shot. Slow, but you see that it does exemplify that quick phase to the left, sort of rotary up. Usually not on this. When you sat her up and you had her turn her head to her right side, because this is her left, and went back, then you would see it. It is possible to have both canals, both sides. It's not as common, and usually there's one side that's much more vigorously affected. So how does that differ from what this guy's nystagmus looks like? He has that horizontal nystagmus. So he has a, besides having like really big eyebrows, he has horizontal nystagmus. This is horizontal canals affected. And it really is only one more maneuver that you do on the Epley. It's called a barbecue roll for the horizontal canal. All right, just more planes again. And this is what's happening when you do the maneuver. My little animation. 3 hours of work. No, one more time was so cute. Oh no. So we're going to practice now. Everybody's going to do it. We've got 3 stations. We have a lot of people in a tight room, but we have 3 stations, and I want everybody to practice. We all ready to practice? Oh my God, it was so weak. I didn't make you guys go around and say, hi, my name is John. I'm from such and such. I mean, you can just be a little bit more enthusiastic. All right, I'll take it, please. Oh, fine. All right, so I apologize to all of those that may be on Zoom. We are now going to step away from the mic and make each other nauseous. So, there we go. All right. Okay, so we got a table here, table in the back, and we recommend breaking off some groups and getting tables put into a position that is usable. This one is usable.
Yeah, sure.
Thank you. So, experience, very good. We know yeah.
Slowly would bring over.
You don't have to try to stop it.
And then you're gonna start the one to put it over. Yeah. On the table. That's the middle one. Now I want you to look down at the. Looks like hold on, it's holding you. Something at the reason number, hold on your arm there. You're gonna wrap right here, it's okay, now it's, we're gonna have a new responses too. So. Yeah. Yeah. And then I don't know. Then you want to take it out, sit back up, it's your next little file. 30 seconds to a minute, just let them settle down. And then come back down. And it feels like if I bring them back down. Right. That's a question for. patients, so that it might not feel like the trash, feel like that, that's one more thing. They're having symptoms. Yeah.
Every time I move, they vomit. And it's not. Feels like it certainly needs it. Yeah.
And I said, okay, you're gonna bring this.
So it's exciting to me as a patient, never mind. Which they can do on their own.
They go right side unless somebody tells me that they have a. There's not. There's no.
It's the left side. You're going to practice the right side. Then repeat it again with that. That's on your guys. Then they'll get that later on. I was there.
And then let it sleep. Like you just gave her. So that was he was forward to you bring it down, you bring it down, and you're not symptomatic. I'm not symptomatic. Yeah. But sometimes you get.
Well, you also need a space where, so that is maybe small, so the mind is not in need of bread.
That's why I like, when it's in a video, I just name it. Right? Everybody has a.
Patient feels more confident because your hands are, there's definitely a difference when you're timid, and then you find and then you get a strong. It is weird, but yeah, like. All right, next, you guys. You got all off this third now. Maybe has to be Apparently it's moving around. It's kind of medical. All right, so we're gonna be in this. If it hurts, the great part about it is that's what's going to be remove those crystals. So looks really looks to the right. Yeah, shouldn't move. How you doing? Probably hard. Drip, the drip more than 30 degrees. Well, makes it doesn't right. That's why I'm stuck on the left side. Traditionally, when it comes to my son, practice everyone beyond their
Oh, your part is already said. The posterior chemistry points, the fact that you just start, Steve, look at this. Hopefully this side. This you said, it's not like you know, but since you never built it. Well, like, I was showing, so I affected some of the both areas down, left side, right, the big against the down. Yeah, so really, it's more serious. No, it's been down. Just consider it's like, if you're sentence, that's all. Yeah, that's. Using the I think it was fine. And I know it was 25.
I didn't have the basic. Yeah.
And seeing how they find like see it.
No, turning around to the inside.
Yeah. But that's the goal. It's something that we
No, it's the whole time you're like both ahead.
Yes. Very hard. Thank you. Yeah. Yeah.
Formal reminder. I think I got that. I think I'm better look at that and see what I yeah. had that when I was medic, my neighbors, they're it's like a break down. So that's surgery. Monsters, yeah. He ran and got me. So dad said, never mind. Get this in. This. I will, for sure.
If anything, that's tomorrow.
Something else, what I'm gonna do. How it's not just in the future that it does the trick, it's actually it's thinking that it's gonna go around slowly. If anything, I won't remember this on master projects and everything, but just the speed and knowledge. Those things flow and get it. There's no need to. Going that So here, you know, we all started on the feet, came down, and then you're sitting on and of course, when you do it the second time, you just start the you still do the whole thing. Okay, I'm trying to say, you're still gonna.
Okay. Yeah.
So that's why you. It's not.
And then.
Right here. What's the way that you can do it? You know, kind of cute, but I appreciate it. It's more simply than I love this video. I literally need to like just a bigger version of single recipe. And then these are their dimension dogs. And they're really good. So the video is kind of it. So when people are like use our ground on this, they have a version very small and see that you will see from the vessel. So we have a freckle in your iris, and you can spot with that. You can see that the rationale that's with goggles, and cell goggles, or like these goggles that have they just make your eyeballs blue big. But and this is yes, and the video version is infrared, so you can do additions in the dark. Or you can provide them with a fixation light. And then you put them through the universe, and you will see the program. And you'll see them stack. You'll be able to see which direction, where it's so big. Computer screens on and the video, if the video in the eyes here, okay, but then the other camera that you set up is your camera only light. And you can real time watch back what position the patient is in and what their eyes are doing. I don't report on it, so you can say, I don't in with this condition, and when you're going through stuff, that is right, if you do a lot of stability. Something like this is probably good for.
Yeah, yeah.
It's not gonna do this, you know, we're not.
But I've never seen it. You see it, putting in the. That's well, we would refer off to the, or you think.
Where this therapy or and then they've got some courses. Some of them are more than all. Yeah, it's like yeah, I am source for Montreal. Yeah, I will cut the 2 hours for and 3 hours for the let's
It's like, I understand this, it's kind of important, like, Nova Scotia, I agree. Here, so.
lots of lakes. Lots of lakes, yeah. And the 4 colors is probably the best. Vermont is considered to be the best. It's going to the Adirondack Mountain range is beautiful. Yeah. And it's the beginning of Appalachian Mountains. Your hands are on some Maine. They don't really cut through that part of the trees and mountains. So there's Catskill Mountains and Adirondack Mountains and then Berkshire Mountains and Massachusetts and the Appalachian Mountains. And it ends up in Tennessee, I believe, right? It starts in Georgia. Well, it starts in Georgia and ends up in Maine. Yeah, it's India. Amazing. Nice. A little bit of Georgia. Thank you guys. You guys made it. And thank you for your help.
Yeah, you take over my spot.
Thank you.
Well done. Everybody loved it.
Hope so. They were just blowing smoke.
No, they loved it. But I didn't have.
No problems. We have to look the right way.
Stop it.
All true.
No.
The best of you suppose.
Oh, trust me. I don't even recognize myself anymore. I used to be cute.
That's a great t-shirt.
Yeah, I used to be cute.
I used to be cute. Great. Interesting for you.
Oh, no. 1 o'clock.
It's no, we're at 3 o'clock.
Oh, you're 3 o'clock, you're right.
I have to take this into the room. I do want to go to this show I announced EPA's what are they?
Yeah, let's do it. Just bring us with us for now.
Yeah.
Where is she?
I think she's in the making movie, yeah.
I might have already seen this presentation.
Come on. What you What with the next that any other? Well, then there is the next one. Very long. It's funny anyway. Probably 3 o'clock. It's pretty funny. Yeah. I'm done with this stuff. That one's education. I don't know if you're in the speaker. Oh, no, I guess I shouldn't be. Oh, this videos.
Oh, maybe I met her around. I heard you saying to TV on the trail.
Oh, literally, I know all things. But you know what time that is with us.
It's small here.
I know. And I praying on finding this. It is small.
Was meant to be. She's from the normal.
Small it is, one of the.
Yeah.
So 2 blocks from here, just across the street and like on Manor Court, that's where his parents live now. Like, stop by and say hi. People are like, we run. I'm like, no, I get this. Yes.
Come on, you go.
So I uploaded mine last night. You know, I had to do individually. I uploaded mine on next thing.
But I mean, you don't have a.
Oh, you mean the notes, like
Yeah.
the presenter mode?
Yeah.
No, it was weird.
Just the present-
Stuck on it's just like the raw presentation.
Oh, I think,
Stuck on the first page.
I think because they're doing, Zoom, right? I think that's probably why, so.
Yeah. That's really cool.
I mean, I need the presentation. Unless, I mean, I don't. Looks like it is. Oh, hello, hello. How are you?
You turned very early.
So you have your presentation?
No, that's not my
Oh, no, that's
presentation.
the presentation right now.
No, well, it's. Is this your EPA one that we did with,
Yes, you're exempt.
like that?
Oh, no, no.
You did this already, right? Yeah, yeah.
That's what she's doing. It's just she needs her, her slide deck. That was the wrong slide. That was the last slide.
Oh, I see.
So. Do you want to use your laptop or?
No, if you have, I mean, does this thing,
have an on off? Doesn't matter. I was just gonna use my.
And then this year, that's as expected, right? You've got like high things and positions that are on that like my no, okay. Like I really tell like yes, right. To keep that time.
Yeah.
All right, good afternoon, our last education session of the first day. So this session is Entrustable Professional Activities. What are they and why should I care? And presenting is Shrona Konofsky, who is an associate professor in the teaching stream at the University of Toronto, Temerty Faculty of Medicine, Department of Family and Community Medicine. She was the founding academic coordinator of the Consortium of PA Education Program and is currently the research and scholarship lead at the PA program. She is a Canadian and American certified PA with a master's degree in health professions education, She practices as a PA. She's practiced as a PA in the US and Canada, most recently in geriatric care at Baycrest Hospital, and is a recipient of the 2013 Tom Ashman PA of the Year Award, and a very dear colleague of mine at U of T, Shrona Konofsky.
Okay, hi, everybody. So we're going to be talking about, and I think I have to talk into this because of the Zoom. Normally I'd be walking around over there, so get me at a distance. So we're going to be talking about entrustable professional activities and what are they and why should I care? And I was just walking around the room a little bit earlier, just asking who people were. I'm sorry I couldn't do the same for Zoom, but there are a good number of you who are interested or involved in one way or the other in PA education. So this is a good talk for you. So you heard the information about me, and I just wanted to also acknowledge Dr. Ole Kate because he's sort of the father of EPAs, essentially. He writes a lot. He continues to write a lot about it. It's evolved in different ways over the years since he started writing about it. And I have had the privilege of studying with him, both as a visiting scholar at U of T at times and on different Zoom professional development things. So a lot of what I've gotten from reading about him, but also from interacting with him and asking him questions. So it's been really, really a great experience to know him in that way. Okay, so this is what we're going to talk about a little bit today. The take-home point really is about the link between EPAs and competencies. So I'm going to talk quite a bit about that. And then the question around when does a PA learner become competent and or entrusted to do certain tasks. And a little bit about assessment, EPAs in PA curriculum and assessment, and addressing a few challenges and misconceptions that have arisen about EPAs entrustable professional activities, in case anybody didn't catch that over the years, okay? So first I want to ask you about this particular scenario. So like if you were, somebody was learning how to drive, would you trust this particular driver that I'll describe to you with your loved one? So for example, for this driver, they studied the Ontario Driver's Learning Guide for a really long time and they aced their exam. They spent about 500 hours playing a hyper-realistic version of a driving simulation game. They're a very responsible babysitter in their part-time, babysitter job for 10 years. And overall, 10 years, that's a long time for a new driver. We'll say 5 years. And overall, a very friendly, honest, good, caring person, okay? And they've also taken 60-minute, 10 60-minute driving lessons with an instructor in the car. And they happen to be an award-winning competitive cyclist. So would you trust this person to drive your loved one around? I put that question to you. And those of you on Zoom, you can think about it. I won't be able to get your answers, but please answer. Is it a yes, a no, a maybe? What are your thoughts about it? Probably? Based on?
Past learning experiences.
Yeah, okay, they've done a lot. Yeah, practice. Yeah. No, I didn't say they passed their driver's exam. Didn't say that. Okay, but you can see they've done a lot, right? But, oh, book smart, real smart. What do you mean by that?
People are hearing, they understand everything, they can do the right answers. But when it comes time to actually do the task, they don't demonstrate their skill set.
Okay, so how do you think you would know if they could drive? Assess them, yeah, okay. And how would you assess them? Getting them in a car and watching them drive? Putting it all together? Yeah, good. I agree. Okay, so just 1 second. Yeah, by the way, I did put in all those different versions of what they had as components of what we call knowledge, skills, and attitudes, right? So some of those things were knowledge-based, some of them were skills-based, and some were attitudinal. And yet, with all those pieces together, we still haven't assessed them. We still don't know if they're competent drivers. Okay, so this leads us to talk about competency-based medical education. So we have to understand EPAs, we have to take a little review of CBME. Is that a familiar term to most people? Competency-based medical education. So it should be, or for many of us, it's very familiar, and it's been drilled into sort of our collective heads for the past 30 years or so, started in the 90s. CBME is built on the idea that the physician initially, and later on it has gone to PAs and other healthcare professionals, the clinician should be more than just a technical expert in medicine, because why? The public, a lot of this came out of public demand or need. They demand other qualities as well. Of course, we know the PA has to be a medical expert in the human body, pathophysiology, anatomy, pharmacology, and be skilled in doing procedures like ordering tests. But there's really so much more we know that we need from healthcare providers. We need things like good communication, and, you know, in a scenario where, let's say, they have to deliver bad news, they should be good advocates for patient support policy, you know, for policies that support patient populations. They should work well with others, right? They should be good team players to improve overall patient satisfaction and outcome. In Canada, and this set of abilities and attributes were developed, as you know, into altogether now CanMeds. Initially CanMeds. EPAs came a little later, but in the 90s, this developed into CanMeds. It's a framework, has 7 distinct roles, and each role is broken down further into competencies and abilities, right? And all these attributes and abilities can be observed and measured. That's the idea. That's why it's competency-based. You can look at outcomes and observe them, so that we can ensure that each student that goes through the program, they've reached their basic level of competency. But unlike medical education over the last 100 years or so, medical students at the time were treated sort of the same, going through the same training, assuming they all were ready to practice at the end of it. This is what this image is. It's a tea steeping model of Brian Hodges, this idea that if you put a tea bag into hot water, it'll eventually just steep and turn into tea. So if you put a medical learner into the medical environment, they'll eventually turn into a doctor, right? Not exactly the case, different. Why are we laughing, right? Well, we know that that's not exactly the case. We have to observe, we have to assess. Every learner is different. Every learner gets things at different paces, let's say. So the bottom line here is that the CanMeds framework was at the time a major advance, no doubt about it. One could even say it was a revolution in healthcare education in the last 30 years, as I said, and it allowed for detailed standards across many domains, allowed to the ability to measure outcomes and observations, and it's both detailed at the same time flexible in some way to allow learners, at least theoretically, to attain their competencies. And this is what the model looks like. On the left, you have Royal College of Physicians and Surgeons, CanMeds diagram. Don't call it a daisy. I got in trouble doing that. Make sure. I'll tell you more about that if you're interested. It's a diagram, and overlapping ovals, not petals. And it's been adopted in many professions beyond medicine. At first, it was called the CanMeds. Actually, does anybody know what CanMeds stands for? Well, trivia question. Canadian Medical Education Directives for Specialists. So this was initially designed actually for specialty residents for the Royal College. But it, of course, has been adopted and adapted by many professions in many countries, and so it's gained a lot of recognition and publicity. And each role, there's the 7 roles. So the medical expert in the middle, and you've got your professional, communicator, collaborator, leader, health advocate, and scholar. So those are the big domains, and within those you have a lot of different items that spell out what each one of those competencies is under that role. And then, of course, the Canadian Association of Physician Assistants, CAPA, our organization, kind of has, over the years, developed different versions of this CanMeds competency framework. It is very similar to the Royal Colleges. It doesn't have the diagram, but it follows the same roles, and a lot of the competencies are very similar, just adapted and adjusted to PA needs. And I'm not going to get too deeply into the differences, and more or less that's the idea. Okay, so let's meet our PA student. Her name is Sarah. And we start with the idea that Sarah here is a good student, right? We chose her for our program. Our programs are competitive. She'll do well. And we expect that she'll become a good PA. So she'll become competent, right, to begin practice and eventually an expert. But when she first graduates, she'll be competent in these 7 PA role domains. Roles, domains, different sort of words for similar idea. But it's our job as the PA educators to support Sarah in developing her competency in these roles. And we do this by teaching her and assessing her. But there are a few challenges with using competency-based medical education for assessing and for teaching. And here are just 2 of them. So first of all, we know from our experience that some of these roles are easier to assess than others, right? So famous example, professionalism. How do you assess it? You know it when it's there, you know it when it's not there. How do you teach it? How do you assess it? Very difficult challenge. And there's, 10 Kate gives the example of communication. Like there's so many different types of communication. Who are you communicating with? Are you communicating with patients? Are you communicating with your supervising physician? Are you communicating with other healthcare team members? And so forth. And even within communication, there's different types of communication with a patient. Are you communicating bad news? Are you communicating a diagnosis, a treatment plan, et cetera? So each one of these sort of challenging domains becomes infinitely more challenging when you break it down. And the second reason is that competence involves more than just possessing the required knowledge, skills, and attitudes. It requires the learner to be able to apply it in real life, in the clinical environment. So from our experience in PA education, many of us can grasp this gap between theoretical knowledge and practical application in our learners. And when I say this, many educators nod their head, oh yeah, we know that difference, or we can appreciate that. So it's really the gestalt in practice and putting it all together. And if you think back to the driving analogy, that's sort of the idea, right? Putting it all together. So just briefly, this is sort of what CanMeds looks like if you break it down, the 2019 version. So you've got your 7 roles on the left, medical expert down to professional, and each one of those is broken down further into elements. And I've sort of just tallied up the number of elements, and beyond that, key competencies, so the overriding sort of areas, you've got a bunch of those. And within each key competency, you've got enabling competencies, so breaking it down into further. I don't know if you can see that from here, but it's 109 altogether. So 109 enabling competencies. That's really a lot of little bits and pieces to make sure that you're teaching and assessing. And even one of them has sub-enabling specialties. So if you tack that on, that's 140, right? So a lot of different pieces to this. So very hard to consider. How are we going to teach this? How are we going to assess this? So my question to you is this. Which of these criteria would you use to select a competent PA to care for your loved one? Again, I keep going to loved one because we really care about them, right? So would it be the A+ student? Would it be many years of education, excellent interpersonal skills, or trust that the PA can manage the case? Should be obvious. What? All of the above? Okay, but if you have to pick one, Olena, what do you think? You had to pick D? Are people saying D? How'd you guess? Yeah. So of course, can you trust me with your patients, right? Can you trust me with your loved one? That's what we care about. Trust really is the ultimate test of whether or not you would allow someone to care for you or for your loved one. And we have to trust the healthcare professionals, and we have to trust that they're capable. Whether or not they're capable is often determined by how much trust an expert, such as a clinical supervisor or a driving teacher, will place on the learner. So we'll get a little more about the entrustment decision soon, but the important thing here is that the decision of trust is the benchmark for EPAs to determine that a clinician is able to perform their clinical duties with varying degrees of supervision, which we'll get to also, anywhere from direct hands-on supervision to total independence in the case of physicians. We'll talk about the special case of PAs, and we'll get to that. And what do PA educators care about? So these are the things we care about. We care about, this is in the multiple choice question. This is like the actual things we care about. What should a PA learner be able to do? at different phases in their education. On day one of clinical practice, right? At what point can we trust that the PA learner can do the work without direct supervision? So you can go out of the room and you can trust that they'll be able to handle the situation. And how can we assess the PA learners ready to practice as a PA? Anything else to add to that list, or do people agree with me that that's sort of what we care about as educators? Anything glaringly omitted? It's not a trick question, just audience participation moment so I can. Then we move on. Okay. So this is OLED 10K again. So he says that EPAs are units of professional practice. And when we talk about units of professional practice, we're talking about tasks, or you can bundle tasks into groups that can be fully entrusted. Again, in the case of physicians, we're talking about without supervision, to an individual once they have demonstrated the necessary competence to execute them unsupervised, them as in those tasks, right? So around 2005, 10K and his colleagues started developing this idea of entrustable professional activities that we're talking about today. And the idea was to start with the medical task, right? So a defined piece of clinical work that's done sort of on a daily basis in clinical practice by the physician, by the PA. Actually, some of his earliest work was on PA education, which is interesting in itself. And it's work that must be done and requires specific competencies. And the purpose of this work, of the work that Tenkate and his colleagues did, was specifically to ground competency-based medical education in practice. So that's the length. It's like, how do you put competency-based education into practice, into clinical practice? How do you see it in clinical work? How do you assess it in clinical work? And the idea was to connect somewhat theoretical concepts within CanMeds that we've discussed to the actual day-to-day work that a PA or that a clinician actually does. And that's really key to this whole thing, why EPAs came into play. Sort of this gap in CanMed's, competency frameworks. There are other competency frameworks in the US as well, so similar type of structure, but that the idea that they were very theoretical and very checklisty, and so the EPAs were put into place to sort of bundle them, really. So we have to make a distinction here with PAs, because we know that PAs were working as of now with supervision of an oversight. So it's not exactly accurate to say that PAs develop competence to perform tasks unsupervised. So just to be accurate, the endpoint in PA training and in practice is that PAs can perform the clinical work with indirect supervision. And of course, we understand that even with indirect supervision, there are different levels of trust, right, in general, because let's say a Canadian Forces PA working in Alert, Nunavut, they're closer maybe to the North Pole than they are to their supervising physician, who may be about 2,000 kilometers away in Iqaluit. Where? Okay, thank you for that clarification. PAs that work in emergency departments may work very closely with their supervising physician, while those who have more years of work experience may work seemingly quite independently from their supervising physician and only touch base occasionally. So there's a broad spectrum even within the indirect supervision, which translates into varying degrees of supervision and entrustment in PA practice. Are we good?